Good evening and welcome everybody to today's session. And very happy Diwali, one day after Diwali. Nonetheless, this is our opportunity to wish you all a very happy Diwali. And we are back to conducting these webinars. Yesterday was Diwali Sunday, so we didn't obviously conduct it yesterday. So this is a presentation from Department of Anesthesia and Critical Care, All India Institute of Medical Sciences, New Delhi, and case will be presented by Dr. Gaurav Mittal. So he's a final year fellow in critical care anesthesia at All India Institute of Medical Sciences, New Delhi. And he's been moderated by Dr. Bikash Ray. Sir is additional professor in Department of Critical Care Anesthesiology, AIIMS, New Delhi. And joining us will be a very young and enthusiastic consultant, Dr. Vamshi. Dr. Vamshi completed his fellowship from Gangaram Hospital in critical care a year ago. And I hope this will be good learning for all of you. This is a very common case scenario and very important, and we should get the basics right in this, and we should take home as much as we can from this, and we'll try to cover as much as we can so that all of you are very well versed with this case and its management in the future. It's a common case, and we should know how to manage this case, the whatever has to be done about this kind of cases. So over to you, Dr. Gaurav.
Thank you, sir. First of all, good evening, every panelist, and good evening, audience. And happy Diwali to all. We'll be discussing a case from our institute presented to us with a fever, jaundice, and altered mental status. So we'll be sharing the screen in a meanwhile. My screen is visible to all?
Yes, please start.
And I am audible, right?
Yes.
Okay. Now we're starting the case with the patient details. It's a Vansh Kumar, 17-year-old male child. Occupation, student by occupation, resident of Uttar Pradesh. Information was given by father and it's reliable. Presented to us with the chief complaint of fever since last 7 days, pain abdomen since last 4 days, yellowish discoloration of sclera since 2 days, altered mental status since 1 day. History of presenting illness, child was apparently well till 30th of June, started having a fever on 1st of July, which was high grade, maximum spike reaches up to 104 Fahrenheit, 3 to 4 spikes per day, associated with headache, eye pain, and muscular pain, not associated with any chills and rigor, not associated with sore throat, burning micturition, pain abdomen, vomiting, and diarrhea, not associated with vomiting, altered consciousness, abnormal body movement, not associated with skin rashes, partially relieved on taking over the counter drug, likely paracetamol, as informed by the father. Total drug was like 2.8 gram over 3 days. After 3 days, he started having pain abdomen, which was periumbilical in origin, distribution not radiated into back, flank, or lower body, non-colicky in nature, not associated with vomiting, diarrhea, yellowish discoloration, sclera, or body. No aggravating factors, including postural change, eating pattern, partially relieved on medication prescribed by a local doctor. And there is a significant positive history of having an intake of outside food and water consumption till since like 28th to 30th June, 3 days before the presentation of the illness. Next 5 days, on July 5th, he started having yellowish discoloration of sclera, first noticed by father, which progressed to involve upper body over next 3 days, associated with pain abdomen as described before, yellowish discoloration of urine, associated with vomiting 2 to 3 episodes per day, non-projectile in nature, content was food particle, no blood in vomitus, not associated with excessive itching, clay colored stools, severe backache, bleeding from any side. There's a history of travel and outside food and water consumption as we discussed before as well. There's no history of such illness before or with anyone who accompanied him. No history of intravenous drug abuse, blood transfusion. He was not sexually active. No addiction history, including alcohol. Since last 1 day, he altered mental status for which he was hospitalized as local hospital. That altered mental status preceded by a fever, pain, abdomen, yellowish discoloration of sclera, and vomiting. That is non-projectile in nature. We already told before. Agitation and altered sleep pattern, intermittently disoriented to time but not to place and person. Not associated with any other neuropsychiatric symptoms in findings. Not associated with focal localizing sign, neck pain or rigidity, abnormal body movements. No history of drinking water from a particular utensils. He was referred to higher center for further management. As for the travel and drug history, travel history was positive. He traveled and outside and consumed outside food on 29th and 30th June, 2 days before the presentation of illness. Drug history took over-the-counter drug, paracetamol, 2.8 gram over 3 days. There is no history of any intake of Ayurvedic or alternative medicines. There is no history of blood transfusion or any surgery done in the past. As far as past history concerned, this is not significant, no comorbidity, no seizure disorder, neuropsychiatric issue, asthma or tuberculosis in the past. Sorry, personal and family history, mixed diet, no history of addiction, disturbed sleep pattern since 1 week. Family history not significant. Course in outside hospital, 6 July onward. Patient shifted to local hospital at Meerut. Managed conservatively, received treatment to be presumed malaria, not tested there. In view of altered mental status, shifted to higher center.
So I think, yeah, okay. What is the summary?
It's a 17-year-old young child with acute febrile illness, with altered mental status, with yellowish discoloration of body and urine, associated with travel without any comorbidities and addiction history.
So one sec, just go back. So altered mental status occurred after how many days of fever, and what is the total duration of fever?
The fever was there for initial 3 days. Then altered mental status started. Fever was continuing. Total fever duration was roughly around 7 days.
When he came to you?
When the child presented to us.
So he had fever 7 days ago, and 3 days after onset of fever, he had altered mental status. And then when did yellowish discoloration occur?
Yellowish discoloration occurs 1 day before altered mental status was there.
Simultaneously, 3 day fever for 3 days, and then altered mental status and yellowish discoloration.
Yes, fever followed by yellowish discoloration sclera followed by AIIMS.
Okay. So why do you think he has yellowish discoloration?
Probably the involvement of liver and metabolism of bilirubin is altered due to secondary to involvement of liver of particularly of infective origin.
No. What is the yellow color? Simply that can come.
The deposition of this
So the patient
bilirubin
jaundice.
Bilirubin.
No, Dr. Gaurav, why is the yellowish color? Simple.
Deposition of bilirubin, sir.
Jaundice.
Metabolite of bilirubin.
First, you have to say jaundice.
Jaundice.
Okay. So he has jaundice, right? That's what you're trying.
Right.
Okay. So keep it simple. No, first you have to answer that he has jaundice. Yellowish discoloration generally means jaundice, but sometimes it can be due to some very rare conditions also, which are not jaundice.
But any drug history is not there. Any excessive intake of carotene is not there. So okay, I make it simple.
Excessive history of carotene is very difficult to elicit. These things are not always so forthcoming, and all these causes are very rare. I agree.
Yeah.
But nonetheless, if you are in the exam or anywhere, you are asked what is the yellowish discoloration, first you have to answer jaundice. First you have to categorize discoloration. Even hypothyroidism can develop a yellowish tinge to the skin.
Yes.
So he has jaundice and altered mental status and acute febrile illness. So
yeah,
with altered mental status and febrile illness and yellowish discoloration, what is and he has taken some paracetamol also. So Dr. Vamshi, can you take paracetamol with jaundice?
Yes, sir. Paracetamol also, the excessive doses of overdosage of paracetamol, basically. It the excessive paracetamol, it actually stops the metabolism, the glutathione. It reacts with the glutathione in the liver, and it causes it inhibits the conversions. So there is a reduction in glutathione.
Glutathione stores, but the point is, if a patient has jaundice, okay, jaundice mostly comes from the liver, can come from other causes also. But if the patient has jaundice, presumably of liver origin, can you give paracetamol for fever?
No.
In chronic,
so
paracetamol can be given. It's not like it's hardly contraindicated, because reaction with paracetamol
is not contraindicated. But when you don't know the exact reason for the jaundice, then it is better to avoid paracetamol.
Yes, in case of acute illness, it should be better to avoid it. But in a chronic case, you can give there is different regime recommended for
Yes.
COPD patients.
You can give up to 2 grams per day.
Really, up to 2 grams.
Grams can be given without any problem. Okay. Now, Dr. Gaurav, what is the cause of jaundice here? We have jaundice, which you have said. Why? What is the cause?
Likely cause is febrile illness involving liver. Viral hepatitis can be the first cause that can barring a short history outside food intake, along with yellowish discoloration of sclera, fever. This all indicating a presence of infectious etiology involving the liver directly. So he might be having any viral hepatitis that might be a foodborne, or it might be a tropical fever, and it might be a acute abdominal pathology like cholecystitis or a pancreatitis.
Cholecystitis causes jaundice.
Obstructive jaundice it causes, and we rule out in the history, but without investigation we can't say.
No, cholecystitis, does it cause jaundice?
No, not pure cholecystitis, cholangitis.
Yes, cholangitis. Cholangitis causes jaundice, not cholecystitis. So, jaundice can come from the liver. Can it come from anywhere else?
Excessive hemolysis, liver is normal, still overwhelmed by the breakdown product can produce the jaundice.
Okay, it can come from hemolytic anemias. Any other causes for jaundice? So sometimes certain drugs can cause, rifampicin and all. Okay.
But they impact the liver first, no? Then it causes the jaundice.
Sorry?
They created a cholestatic pattern, then it creates a jaundice. So liver is indirectly involved, even if with the drugs.
Okay.
The basic pathology is with the liver, whatever the drugs which you take. When it involves liver, the jaundice develops.
Okay, agreed. And sometimes resorption of hematomas can also occur. Blood and hematomas can also cause jaundice. Huh?
Yeah, that is also the ongoing hemolysis overwhelming the liver capacity.
Okay. And sometimes there are other conditions also, like congenital conditions like Gilbert's and Crigler-Najjar, which can have.
Yeah, Rotor, Gilbert, and Crigler-Najjar, they all involve the liver enzyme involved either in a transport or in the metabolism.
Okay.
But the jaundice level goes till 2 or 3 in a stable patient. Acute condition can be exaggerated over any acute illness over the pre-existing congenital disorders.
But per se, they don't go for a very high bilirubin values. It's more
definitely.
2 or 3, yeah.
Now, coming to mental status, yellowish discoloration, you mentioned tropical fevers. So one was viral hepatitis, then tropical fever. So which tropical fever do you think can cause jaundice?
Malaria can cause jaundice, sir.
Okay.
Leptospira can cause jaundice.
Sorry?
And Leptospira can cause jaundice.
Okay. Agreed.
And scrub also can cause jaundice.
So many tropical illnesses can cause this kind of a syndrome. They can cause altered mental status also. And difficult to say on this. Tropical fever, agreed, is one of the differential. So cholecystitis would not be likely, but cholangitis, yes. Then liver abscess. So how will liver abscess can cause jaundice, but can it cause altered sensorium?
But if chronically if it is a large enough, it can hampers the sensorium, but not directly as the other illnesses. That is why it's in the lower down in the things. Indirectly, it can cause by hampering the systemic circulation and all. Patient can goes into the shock and can hamper the altered sensorium, but not directly.
No, indirectly meaning what? Simply in 2 words. How does liver
hemodynamic, perfusion, inflammation? These 3 parameters, not the typical driver of AIIMS in hepatic involvement.
You mean it by sepsis, septic encephalopathy, right?
Yes, right.
Not by any other means, huh? Okay.
Not by the direct mechanism, that is being more obvious with the liver involvement like ammonia, manganese, mitochondrial dysfunction and all.
Okay. So Vamshi, can acute pancreatitis cause altered sensorium and so much and jaundice to cause yellowish discoloration?
So basically, acute pancreatitis is not a disease that actually involves that causes encephalopathy directly. But if the patient has any the late presentations of acute pancreatitis, where you have a suspicion of sepsis, which can cause septic encephalopathy, or some causes of biliary pancreatitis, when the basic thing is having a cholangitic symptoms that can cause encephalopathy. I mean, the jaundice.
So have you heard of pancreatic encephalopathy?
Yeah, there is an entity called pancreatic encephalopathy, but that occurs in the late stages of pancreatitis,
Very
not
good.
in the early course.
Very good. So that is, it is not very clearly defined, but that entity is there, pancreatic encephalopathy, thought to be due to cytokines, etc. But pancreatic encephalopathy, like you said, is a distinct entity which occurs later in the stage of pancreatitis, acute pancreatitis. Okay. So further DD you are writing. Okay. So you have written remotely Wilson's autoimmunes, and so now the altered sensorium, if it is due to acute hepatitis, then it's likely to be hepatic encephalopathy, right? So we have to see
Right.
whether it is hepatic encephalopathy, and all those things will come from the investigations. So
Right.
the whole thing be just sepsis.
Hemodynamically relatively stable as the outside document says, no as such a local focalizing cause, no pneumonia, no UTI, no nothing else. So sepsis might be there, but we don't have any source. So we have more obvious reason of defining his illness, like liver involvement of hepatitis or tropical fever. So sepsis might be there, but cannot be ruled out, but cannot be solely this thing labeled for this his current condition, at least.
Cannot be ruled out. Okay, taken. Liver abscess is there. That is a source. That is possible. Okay, you
Yeah.
are written. Then can it be meningitis?
No, although the sensitivity specificity of clinical signs are less, but as per the history we had, there is no such history indication of meningismal sign or a localizing sign. So likely CNS involvement primarily is very low.
So what would you expect if this was bacterial meningitis? What additional pointer would be expected?
The vomiting might be a projectile. There will be a neck rigidity. Along with this thing, there will be any more irritability rather than this altered mental status of somnolence and altered sleep pattern. So, and for this fever might be followed by this altered mental status. This jaundice part will come if it is the secondary involvement of liver, not a primary bacterial meningitis can directly involve the liver this way. So
Yes.
history will be other way around different.
Yes.
Also, in case of acute bacterial meningitis, the presentation will be much more severe and acute. It may be
Yes.
tuberculosis case, maybe it's because the presentation is over 5 to 7 days.
Yes.
That is one of the features.
Also, like you said, doctor, because that jaundice is not a prominent feature. It is, if it occurs, it will be
Yes.
much later. Jaundice is not really a feature of acute meningitis.
Yes.
So
Yes.
acute meningitis is usually defined by only a triad, which consists of fever, headache, and the sensorium disturbances.
But the clinical are very less of these clinical features.
Yes, Dr. Vikas, you were saying something?
No, the clinical features or the triad of the acute meningitis, the sensitivities are very less. Even for the clinical signs, what you elucidate, the sensitivity are very less.
Okay.
And Dr. Gaurav, I need to ask you a question. How did you, in the previous slide, there is acute liver, you have arrived to a diagnosis differential of acute hepatitis, likely viral. Just wanted to ask you why it is mostly towards viral. What
shorter duration,
yeah.
fever that it indicates the etiology of infectious origin, along with this 5 or 7 days altered mental status, and there is a positive history of outside food and water consumption. So all of these, if we see together, mostly fit into this thing rather than going to the other thing. So that is why my first DD is the likely viral. But as we know, the other two entities is like a indolent thing, can flare up at any point of time, might be there, and label it as a evolving ALF because I don't have investigation. So that is why I'm saying it's evolving ALF because of sensorium alteration. I don't have investigations to label it as whether he's in ALF or not.
Yeah, and also the most common cause of acute liver failure in Indian setup. First, we arrive at viral etiology, right?
Right.
So, Dr. Gaurav, the best simple statement is epidemiologically, this accounts for more than 75% of acute hepatitis viral etiologies. Simply,
yes,
epidemiologically. And
Yes.
it is very difficult to distinguish at the outset from other causes. What are the other causes? You have mentioned Wilson and autoimmune, which are very rare. What are the other more common causes?
Other more common causes for liver failure is
Acute hepatitis or liver failure. What are the other causes?
viral, that we have a spectrum A, B, C, A, B, and E mostly. And if pregnant, then pregnancy associated ACLA. Autoimmune Wilson hemochromatosis, one segment. Budd-Chiari syndrome, another segment. And this tropical fever related, drug induced DILI, that is what we labeled it as drug induced liver injury. It may be idiosyncratic or dose dependent mechanism, or it may be a poisoning related, like paracetamol, that is a more common in a Western scenario, or a mushroom poisoning, or other drugs, or a tubercular induced, ATT induced, this hepatitis or hepatic and this liver failure.
Okay, very good. And sometimes shock in the ICU and alcoholic hepatitis. So these are some of the other causes. Very good. So other thing is, you mentioned tropical fevers. So out of tropical fevers, classically things like malaria and leptospirosis and rickettsiosis, scrub typhus, they don't cause liver failure. They can cause acute hepatitis because they can have multi-organ involvement, but they don't lead to liver failure as such. Acute liver failure is not a feature of these tropical infections. They don't cause hepatic encephalopathy. They can cause encephalopathy as such by direct involvement, but hepatic encephalopathy does not occur in these tropical
Nowadays, we are getting dengue, sir, that is
Yes.
causing the encephalopathy as at day one. It might be a dengue encephalopathy, but liver is also involved, so difficult to differentiate whether it's a dengue-induced encephalopathy or secondary to liver involvement.
Yes, dengue is different. Dengue is a virus. But malaria, leptospirosis, and
they have more indolent course rather than the fulminant one.
Dr. Gaurav, speak only after I finish or the other person speaks, otherwise audience cannot hear. Just wait.
Okay, sir.
Wait till the other person speaks. Okay, carry on. Next.
On arrival to AIIMS emergency, airway was patent. On breathing part, saturation was 98% on room air with respiratory rate of 18. BP was 140/80, heart rate of 117. He was drowsy, no documented sedation while shifting from Meerut. On VBG, he is having a pH of 7.4 with PCO of 38 and a bicarbonate of 21 with lactate of 1.7. CBC includes a higher TLC count with lower platelet count, 90,000 platelet count, and the index creatinine that was available to us at on presentation was 7.6.
So just go back, Dr. Gaurav. So, Dr. Vamshi, can you tell what is the difference between VBG and ABG in terms of values? What is higher, what is lower generally?
Generally, the PO2 and PCO2 is what we consider the difference between ABG and OBG. The pH will almost remain the same, and according to this remains to be.
PO2 is okay. What about pH and bicarbonate? Any difference, ABG and VBG?
Not much, sir.
The slight difference is there just for sake of specificity. ABG and ABG are common things. There's a slight, the venous blood is more acidotic to some extent. Bicarbonate is slightly low, and ABG venous, so the pH also becomes slightly low. And of course, CO2 and O2 differences are there. So that should be known to everybody because VBG is done sometimes and we have to interpret it. And the other thing is chloride is 113. So that is a high chloride. Why is the chloride high, Dr. Gaurav?
So he might received hyperchloremic solution during the outside hospital stay. We didn't have any paper for that. Along with he has AKI, onset of AKI is there. So both of can lead to chloride retention. So both of them can lead to hyperchloremia.
So hyperchloremia is a feature of AKI?
Usually not, but capacity to retain get rid of chloride reduces once the AKI sets in. So when we are giving hydrogenically a chloride containing solution, so tendency of bodies to retain the chloride will be more as compared to the normal renal function.
But if the tendency to not clear the water and chloride, then water will be retained also, right?
Right.
Hyperchloremia is a feature of AKI. Hyperchloremia occurs generally in two conditions. Either you are giving a lot of sodium chloride or if the bicarbonate goes down. in normal anion gap acidosis. These are the two main conditions. So we are not clear why chloride is increased. Okay. Now, very interesting is creatinine is 7.6 and your bicarbonate is only 21 and pH is 7.34. So Vamshi, is this compatible?
Yeah, it looks like a evolving AKI.
No, creatinine is 7.6, Dr. Vamshi. There's a discordance in the VPG and the creatinine value, right?
Yes, sir.
What is the problem with the VPG and creatinine?
Bicarbonate looks almost in the normal range while the
So
creatinine is rising.
can you have a normal pH with a creatinine of 7.6?
Difficult to say that.
You cannot have a pH of 7.34 with a creatinine of 7.6. You have to have acidosis. You have seen so many cases. Have you ever seen
Yes,
a
sir.
near
No,
normal 7.34, 7.35 with 7.6 creatinine? It is not physiologically possible. Not a
not
Gaurav,
frequently.
comments?
He might have received soda bicarb outside, sir. It's the index VBG we had. So we don't know what kind of fluid he has received
Soda
before.
bicarb, that is the answer here. So these things sometimes get hidden, we don't get the history and it's very difficult to fathom, but that is the answer. He has received soda bicarb. There's no other explanation for this. Okay, so he's drowsy already and the saturation is okay. Any comment on the blood pressure, Dr. Vamshi?
Blood pressure, he's on a normal side, only a little on a higher side, but the heart rate is on a higher side.
So the pulse pressure is also wide, Vamshi,
Blood
140 by
pressure is wide, signifying a bit of septic component also.
No, is it necessary that it is septic or it can be because of acute liver failure also?
Yeah, it can be due to acute liver failure also.
Acute liver failure has the same, no? It has a surge physiology. There's a vasodilatation.
Yeah.
Huh?
Basically, the cytokine, the thing which can cause the increase in pulse pressures.
So I request everybody, please speak only when the other person stops speaking because otherwise the audience cannot hear the voices, they clash together. Please speak only when the other person stops. So that is the presentation in ED and he's drowsy. That is the most important thing. And creatinine is 7.6, platelets are 90,000 and TLC is raised. Okay. He may be in sepsis, that has to be seen.
On further course, on next day, patient become more drowsy, GCS dips down to 9, so he got intubated in view of low GCS. Meanwhile, USG abdomen was done that shows a mild ascites. Gallbladder wall was significantly thickened, but there was no stone, sludge, or intrahepatic biliary dilatation. Liver and spleen commented to be normal on parenchyma. CT brain was done because there was a deep GCS that was suggestive of raised ICP. For sulci gyri was effaced. There was effacement of this when these species and all, but otherwise no focal lesion was found to be on CT brain.
So just go back, Dr. Gaurav. So, Dr. Gaurav, there is mild ascites. What is the significance of mild ascites? Is it important?
Usually, ascites doesn't come in a very acute pathology, but if it is there, it might signify some underlying abdominal involvement or subchronic involvement as well. So, mild ascites.
So he may be having chronic liver disease, acute on chronic liver disease. It's very important here.
Maybe.
When a patient presents with acute liver disease like presentation, we have to rule out acute on chronic liver disease because chronic liver disease, there are no symptoms sometimes and the patient presents with acute deterioration, what is called acute on chronic liver disease.
Yes, sir.
So this is very important, but generally there would be splenomegaly and you can get portal collaterals when you do the ultrasound, which signify portal hypertension. So mild ascites, very rarely you can get in acute liver disease because portal hypertension develops because the liver architecture gets destroyed. So there is resistance to inflow from the portal veins. So portal hypertension does occur and you can get mild ascites. And sometimes, the virus itself can cause a little bit of serosal inflammation. But definitely when you get mild ascites, one's mind should be open to the fact that one may be dealing with chronic liver disease. It's very important because the treatment, the outcome, and the prognosis of acute and chronic liver disease is totally different. Dr. Vikas sir, any comments?
No, it's okay. Okay. Gaurav, what is the significance of other findings in the ultrasound abdomen, like
So
the
this GB thickness is actually a marker of microcirculatory dysfunction, but the odds ratio associated with thickened GB in acute febrile illness is very much associated either with dengue or hepatitis A. So if we go with the review of literature, if we find a thickened GB with this kind of picture, we should always rule out these two entities together, like dengue and this thing, hepatitis A. Hepatitis A odds ratio is somewhere around 4.96. So getting an acute viral picture along with this thickened GB almost indicate towards you have to rule out hepatitis A.
also in case of dengue, you say the sludge
Yes,
is
sir.
much more prominent along with thickened GB, thickened.
Yes, sir. Yes.
So thickened GB, is seen in dengue is because of the inflammation of the gallbladder serosa and can be seen in other viral etiologies, can be seen in hypoalbuminemia, can be seen in generalized acute hepatitis, can be seen in congestive heart failure. So there are a few causes of gallbladder thickening. Essentially, it means that there is serosal congestion, there is fluid in the serosa of the gallbladder, and like Gaurav has said, it can be seen in dengue, can be seen in viral hepatitis. Okay, Dr. Gaurav, move on, please.
And it's also association with the prognostic value. It has a prognostic value. If we patient presented with this kind of picture along with the hemodynamic instability, the prognosis usually is grave. So it also has a prognostic value. So the investigations done, one investigations we have from outside that signifies the significantly raised OTPTs. Total bilirubin was 8.5, among that 7.4 of direct one. Urea create was on a higher side, and deranged coagulation was there. So on ED presentation, thrombocytopenia is worsening, dips to 80,000 from 1 lakh. OTPT is still rising. Bilirubin remains almost static. Ammonia level was done on index presentation, comes out to be 380. Viral etiology wise, HBS, AG, HCV, and HIV comes negative, and INR become progressively deranged as he stays with us.
So, Dr. Gaurav, why is the TLC raised?
Inflammatory response or superadded infections, sir, both can be there because he has a hospital stay outside, as well as because once liver is involved, patient becomes immunocompromised. He has a tendency to acquire infection, especially in the hospital setup. So might be it's only a reactionary thing, it's an inflammatory phase, or it might be an ongoing or new onset of some hospital acquired infection may be there.
What percentage, very good, what percentage of patients develop infections, in the first 48 hours or at presentation in ALF?
Indian data is quoting it very high, sir. Somewhere around 60 to 75% patient usually have some kind of secondary hit from a hospital acquired infection. It all depend upon the presentation severity. If more of organ dysfunction, more of encephalopathy is there, then chances are more that it might be associated with acquired infection from the hospital or the surrounding.
Yes, so around 50% of the patients either have an infection at presentation or develop within 48 hours of admission. So the index of suspicion for infection should be very low. Now, you said that these patients are immunocompromised patients with acute liver disease. And I think we can categorize this as acute liver failure now because your ammonia is very high, is in hepatic encephalopathy. So we categorize this as acute liver failure. What is the diagnostic criteria for acute liver failure, Dr. Gaurav?
It involves the three things. And the one thing is bilirubin, another thing is OTPT raised, and the third thing is deranged coagulopathy, and fourth is involvement of consciousness, that hepatic encephalopathy.
No.
Only there are three criteria, Gaurav.
Yes, sir.
Acute liver injury along with the hepatic encephalopathy and coagulopathy.
Coagulopathy. Bilirubin is not there in the part.
Yeah, some definitions like the older European Society guidelines, they have a jaundice criteria. Also, the Indian Society of Study of Liver has a older criteria which has jaundice, but now it is much more accepted that acute liver
Liver
injury,
injury.
coagulopathy along with hepatic encephalopathy. These are the three features you require for a diagnosis of ALF. Only with certain exceptions like 2 case, it may be a chronic ongoing Wilson's. In those you exclude.
Hepatitis B reactivation, autoimmune.
Otherwise, this is the three criteria. There is no fourth criteria for.
Yeah, so Dr. Gaurav, enzymes are not involved. Enzymes are generally less, but they are not diagnostic criteria. Diagnostic criteria is acute deterioration in the patient's condition with the development of jaundice followed by encephalopathy with an INR greater than 1.5. Just to keep it very simple. Enzymes are not part of the diagnostic criteria, so normally they are raised. So this is the diagnostic criteria. So this is very important. Diagnostic criteria and the definition should be very clear. So you have acute liver failure, and if you don't develop hepatic encephalopathy, but if you have jaundice and liver disease and INR more than 1.5, it is called severe liver injury. And acute or chronic liver disease is deterioration in a patient's condition acutely who has chronic liver disease, and of course then you have chronic liver disease. So these categories of liver disease should be cleared in mind, because acute or chronic liver disease is very important, because patients of chronic liver disease are silent and they just present like acute liver disease. So one should always look for stigmata of liver disease, and especially history. When alcohol is very important here. Of course, he's 17 years old, but I've seen 17 years old who started drinking at 12 years age and who developed chronic liver disease with alcohol. So the diagnostic criteria should be very clear. Now coming to platelets, you said TLC. What is the basic physiology in acute liver failure? What happens to the systems, all the systems in acute liver failure, Dr. Gaurav?
Firstly, the liver is involved, that leads to, because of hepatocyte injuries, so metabolism will be deranged. So one thing is that injury to the liver causes spillage of the intracellular enzyme that causes the raise in OTPTs and other parameters. Along with detoxification of certain these metabolites were reduced, like ammonia, and significantly raised, and it can affect the other body system, along with the release of several cytokines, inflammatory markers that were created as the state of immune suppression, along with the vasodilatation that affect the systemic circulation as well. Along with, there is a sequestration of cells, marginalization of the vascular these cells, so that leads to this, and there is a reduced production of thrombopoietin. So platelet production will be reduced, marginalization will be increased, and vasodilatation and this vascular volume is high, so dilutional this thing thrombocytopenia is observed during the acute liver involvement. Fifth thing is derangement of coagulation, because if it is an acute injury, then there will not be a balance between pro and anticoagulation. So balance derangement will be there, and patient might have a significant bleed along with, if it is acute liver. But in acute on chronic or chronic thing, it's a very different scenario, because hemostasis will be there and other parameters looks into the align into the things. Another systemic thing is involvement of renal system and involvement of pulmonary system and cardiac system. So hepatorenal syndrome, well-known entity; hepatopulmonary syndrome, well-known entity; and cardiac involvement secondary to hepatic dysfunction. So every system can be involved depending upon the etiology, severity,
What is the
and
basic
duration.
physiology in which all the systems are involved? Underlying physiology, in one word. There you have renal involvement, you have pulmonary involvement, you have hypotension. So what is the basic physiology? In one word.
Component of SIRS or vasodilatation?
Yes,
I don't know.
simply. Acute liver failure has SIRS physiology. Huh? So
Yes.
why do you think there is renal failure with a creatinine of 7.6?
We have 7.6. It might have evolved from this thing, because he has a duration of outside stay. So it's a relative deficiency of intravascular volume because of this dilatation of the renal vessels and relative insufficiency of blood to the renal system that creates this kind of picture. It might be in a hepatorenal because of under resuscitation, or it might be a direct insult to the renal from the primary etiology that is affecting the renal liver system.
Okay, so two causes you have given. One, because of hypotension, there might be a pre-renal kind of a renal failure. Okay, because of vasodilatation, but the blood pressure is quite good, but blood pressure may still be good and the patient can be hypovolemic in terms of intravascular volume. One. Second, you have said he might be having a HRS kind of physiology. Agreed. Second, those are two causes. Third, he may be in sepsis. And fourth, he may have developed acute tubular necrosis because of SIRS physiology. Just like in sepsis, you get ATN because of surge physiology. Similarly, in acute liver failure, you can get ATN because of surge physiology. So these are the normally four causes of acute renal failure in uh, acute liver failure, AKI in acute liver failure. And we have to look at drugs also. We do not know whether what drugs he has received outside. Some amikacin, aminoglycosides, or something he has received which has caused drug-induced liver injury. And it's important to look at the urine microscopy also. So we know we then generally don't look at urine microscopy, but when there is so much renal failure, one should always look at renal all parameters, especially urine microscopy. Sometimes it is quite rewarding. Okay, so moving on, your bilirubin is direct. It's 8.5 to 7.4. So, Dr. Vamshi, when do you say bilirubin is indirect?
It is the direct component is more than 50% of the total component. We call it as a conjugated bilirubinemia.
So, Gaurav, you agree with that?
That 15% ka cutoff we have for indirect one, but once the conjugated raised to beyond 50%, we labeled it as predominantly conjugated bilirubinemia.
Actually, by definition, more than 85%, if it is unconjugated, then it becomes indirect. Otherwise, it is direct. But if it's nearing that much, that we can take it as indirect and direct. Okay. Now, albumin is slightly low. It is gone to 3.03. And creatinine, urea creatinine is in renal failure. We have already talked about that. Ammonia is 380. So it is increased. And coming to HbsAg, HC, HIV, negative. So you have done the test for HbsAg, HCV, and HIV. So it does,
It was
out of all the hepatitis A, B, C, D, E, which ones cause viral hepatitis, acute liver failure?
mostly it is either A or E that is more prevalent in our setup or in our country. But sometimes it's acute reactivation of B, hepatitis B. That is why the duration of ALF that is like less than 26 weeks doesn't apply if patient have a hepatitis B in the background. So usually it's A and E, but B can cause.
Okay, B can cause. A, B, and E can cause. Okay.
Yeah.
So HbsAg is negative, HCV is negative. So if it is caused by hepatitis B, can you get HbsAg negative? Supposing
Clearing,
this patient has
yeah,
B causing acute liver failure, can the surface antigen be negative?
because the injury is more or less depending upon the immune reactivation because of hepatitis, not per se the hepatitis is causing something. So it's a body response to the this surface antigen. So it might get cleared off when immunity is so high that it's causing the error. So it might be negative in actual presence of hepatitis B related.
How you will
This.
pick it up?
Then core antigen and other parameters of
Okay, very good.
hepatitis B should be.
Okay, very good. So you have to do IgM core antibody here. That should also be sent in these cases. You can get that negative. Okay, agreed. So next, move on. And OTPT is very important. Here is 3,000 and 4,000. Now coming to OTPT, alkaline phosphatase is marginally increased. That is what is expected. So, Dr. Gaurav, what is the significance of OTPT more than 1,000? Any diagnostic value importance?
Viral etiology are more commonly associated with raising the OTPTs more than 1,000 because acute necrosis will be there, then only levels will go this high. So it signifies two things. Is one thing is acute, second thing is this viral etiology is behind. So we have to rule out first the viral. Second one can be associated with drug induced, especially with the idiosyncratic reactions. So these two causes are more prevalent, causing these OTPTs to go high. This high.
Gaurav, also ischemia is one of the causes in which that will go into thousands.
Yes,
Yes, sir.
Dr. Vikas sir, very good. So there are only three causes which cause OTPT more than 1,000. They account for 95% of the cases where the OTPT is more than 1,000. So this is a diagnostic clue. Very rarely things like Wilson's and autoimmune can cause more than 1,000, but that is less than 5% of times. See, if you have a OTPT more than 1,000, just rule out viral, drugs, and shock liver. Shock liver is apparent, right? The hypertension occurring acutely. So drug history becomes very important here. Then you can look into the drugs and the virus. So it's very important. It's a diagnostic clue. Okay, Dr. Gaurav, move on.
So he received empirically ceftriaxone and doxycycline in view of suspected tropical illness. Neck infusion was started, tablet rifagat was added, syrup loose was added. All three is according to institutional protocol. 3% NS 100 ml TDS was started in view of anti-edema measures. Gastro opinion was taken. They asked to continue with anti-cerebral edema measures, monitor and explain the poor prognosis to the patient attendants. Nephrology opinion taken, as it was a non-oliguric AKI, they said to manage it conservatively. In view of AFI thrombocytopenia, AKI requiring mechanical ventilation for poor GCS, patient was shifted to RICU.
So Dr. Vamshi, just go back. What comments would you like to make as far as evidence is concerned for NAC infusion, tablet rifagat, and syrup loose?
Yeah. First, when you come to NAC infusions, the definitive role of N-acetylcysteine is consistently established in paracetamol poisoning. But the evidence is evolving in non-paracetamol poisoning, the non-paracetamol causes of ALF also. So presently the ALF, American Association on Study of Liver Disease, they recommend starting NAC infusions for non-paracetamol etiology of liver failure also when it is NAC.
Okay. So it is, and it has been found to be helpful primarily in hepatic encephalopathy 1 and 2. There's not much of a benefit in 3 and 4 stage, but it is not harmful. So recommendations are to give NAC, and it has become the standard of care in non-paracetamol acute liver failure also. What about rifagat and loose, Dr. Vamshi? Any evidence for this?
Rifagat and lactulose, they are most useful in the chronic liver diseases. The evidence for use in acute liver disease is very scarce, and it is that can be decided on case by case only. But as such, the evidence is not robust in acute liver failure.
I agree, Dr. Vamshi. Very nice. So rifagat and loose are neither here not there. You may or may not give it. No harm in giving it. And like Dr. Vamshi has said, case by case basis you can decide. Now coming to 3% 100 ml TDS you are giving to this patient. So anything you want to target here when you are giving 3% or you're giving arbitrarily, Dr. Gaurav?
Sodium should be targeted. It should be reaching, like, initially it should be targeted around 150, 155. If it is not being controlled, then can raise up to maximum up to 160, targeting a serum osmolarity of 320. Try to avoid any acute ATM because of hyperosmolarity and increased serum osmolarity. So target initially 145 to 150. If it is not getting controlled, can raise up to 160. But serum sodium monitoring should be there when we are using 3% NSA.
Okay. Agreed. Now coming to gastro opinion, anti-cerebral measures, any role for hyperventilation here?
For acute, when where there is an impending sign of any herniation or any acute localizing sign, for short time, like for once in a while, like for getting time by to time so that your osmolar therapy works, we can hyperventilate, but not for a prolonged period, because it associated with paradoxical increase in cerebral edema and another cerebral injury because of vascular involvement associated with hyperventilation or hypocarbia. So prolonged is not this thing. We can allow spontaneously patient to hyperventilate, or we can induce hyperventilation for a brief time to buy some time.
No, but what is the problem with going on for a longer time?
Hypocarbia actually causes the vasoconstriction and further impeded the cerebral vascular perfusion. So if it is not associated with decrease in edema, so perfusion pressure will go down eventually. So it will cause more injury rather than preventing anything else.
Okay, agreed. And also after some time there is a there is a refractory stage reached also. So there is a degree of refractoriness also. It is only useful for short-term measures. Agreed. Now coming to nephrology opinion, conservative for non-oliguric AKI. Now the patient was passing good urine.
Yes, sir. He was passing good urine amount around 2 liters per day for 24 hours.
So is non-oliguric AKI better or AKI better, or there is no difference for the patient prognosis?
Studies are coming up, sir, for labeling AKI. In a recent ICM study has published where they labeled whether you had defined AKI on the basis of creat or other parameters or urine parameters. So they say if AKI is classified on a urine parameters. Prognosis is better with this one, non-oliguric AKIs.
Any reason you want to give?
It may be this vascular changes rather than the primarily tissue damage that is causing this one non-oliguric AKI, so that recovery might be a good as the primary insult is taken care of. I don't know exactly.
It's okay. Dr. Vamshi, any comments why the prognosis for non-oliguric than oliguric AKI?
Whenever you see the glomerulus and the tubular functions for the cause of AKI, when you get a ATN, which is, the interstitial disease or a tubular functions, they usually cause a decrease in, they don't cause any decrease in AKI, urine output. When it is related to any glomerular disease or afferent arterial disease where the pathogenesis is different. So usually they say that the non-oliguric AKI would resolve sooner than an oliguric AKI. It's not the actual good or bad, but the which resolves early or late.
Okay.
That's my goal.
Okay, so see, briefly, this is not very clear. First, at the outset, non-oliguric will have a greater urine output and greater washout of electrolytes and better control of acidosis because he is producing more urine. So things are better for the patient in terms of the metabolic milieu. Secondly, whatever physiology to which you have alluded to some extent occurs in non-oliguric AKI is better to the patient than an oliguric AKI, as far as the kidney physiology and pathology is concerned. So that is what is the current knowledge about this. Not much detail is there in terms of pathology and physiology, but that is the current understanding. Okay. So please carry on, Dr. Any comments, Dr. Vikas, sir? Please.
Yes, sir. I just want to ask Gaurav, why do you choose 3% saline rather than any other anti-edema measure? Is there a specific reason?
Now the lot of literature has come since last 1 or 2 years. Which one should be preferred? Which one should not be? As per the guidelines, nothing is recommended from their side, but there are some consideration that has to be taken. First, patient should be passing urine or not. That has to be taken care of. Second thing is the reflection coefficient of things that is being in use, and more tightly control or more significant monitoring is there or not. So out of mannitol or 3% NaCl, we choose 3% NaCl because monitoring is relatively good. Rheostatic, this reflection coefficient of NaCl is 1%. So for acute use, rebound hypertension is less chances as compared to mannitol, although on chronic it can occur. Third thing, mannitol, already patient is having AKI, although it's non-oliguric AKI, but mannitol we have to monitor the serum osmolality and osmolar gap. That is a bit tedious thing to follow in the ICU setup. So mannitol was deferred, and it can be preserved for using it on acute SOS basis where herniation is impending. Patient is already receiving 3% NaCl, and we haven't achieved the target of 320 or 340.
So, Dr. Gaurav, what is reflection coefficient? Now that you have said.
Reflection coefficient is key when we withdraw the certain drug from the system. So that can cause the rebound thing, because if it is not equal in both sides of the blood-brain barrier, it further paradoxically, when drug is being cleared off, it causes this thing edema to happens again. Because once it is redistributed against both the compartment, we have taken it out. Now it can causes the rebound edema and rebound retention of water in that compartment, and then lead to the worsening of cerebral edema.
The ability to cause rebound increase in ICP because of crossing the blood-brain barrier.
Yes.
So what is the reflection coefficient for 3% and hypertonic saline and mannitol?
Mannitol is 0.9 and this 3% NaCl is 1. So relatively marginally difference is there, but theoretically they can cause.
Okay.
Mannitol has less, so chances are more that it can cause rebound.
Then you mentioned mannitol and renal failure. Can you give mannitol in renal failure at all?
Urine, if it is urine output is less, there is no to mannitol definitely. If patient is producing adequate amount of urine, for a rescue therapy, I might be considering, but for a regular ICP monitoring, if I am having a serum osmolality before every bolus, I can measure it, then I can give. Otherwise, I prefer to go with 3% NaCl.
You can give mannitol, supposing the patient has some contraindication to 3%. Sometimes there are contraindications, right? So mannitol can be given in renal failure provided you do the dialysis after mannitol.
Yes.
So sometimes you have to have all options open. Then after giving
Yes.
mannitol, shortly after that, you have to do the dialysis. Now, nephrology opinion is conservative for non-oliguric AKI. So what is metabolic dialysis in acute liver failure, Dr. Gaurav? What is meant by metabolic dialysis?
It's a support, basically renal support system, which we give despite we don't have any compelling indication for going to the RRT, like significant oliguria or significant refractory hyperkalemia, refractory acidosis. We are just providing the support, metabolic support that is being there to them because of metabolic alteration secondary due to the liver injury. Just for the support when we give the renal replacement therapy, rather than per se the compelling indication is some metabolic renal replacement therapy.
So what is the parameter here for which we can do metabolic dialysis? Is there any indication to dialyze the patient apart from the usual indications?
Ammonia can be removed. Studies are there, like ISD is equivalent to CRRT, but definitely CRRT over 24 hour reduces ammonia level more as compared to ISD. So ammonia is one thing that can be changed, but how it reflected to clinical outcome is still a matter of debate.
So ammonia is responsible for raised ICT, right?
Right. Primary driver for the ICT is ammonia, but it leads to certain kind of mechanism that perpetuate itself even without the presence of ammonia can lead to persistent raised ICT. So chasing down only ammonia is like the debatable issue, but can be tried.
So how does ammonia lead to raised ICT?
Basically ammonia crosses the blood-brain barrier freely, and it has a predilection to enter to the astrocyte. Astrocytes are the major metabolite site of the brain. That astrocyte, ammonia enters the astrocyte, changes the intracellular environment. Along with, there is a Trojan horse theory, like ammonia is picked up by the brain and glutamate being added to the ammonia, becoming a glutamine. That glutamine is entering into the astrocyte, and that glutamine entering into the astrocyte releases the ammonia inside the astrocyte. That reduces the intracellular pH, further increases the intracellular calcium signaling, along with reactive oxygen species and reactive nitrogen species inside the astrocyte. That all leads to the persistence of mitochondrial dysfunction, and that mitochondrial dysfunctioned mitochondria doesn't get cleared off from the body, from the blood circulation. So all of these leads to the cellular injury at cellular level, leads to the raised ICT.
Gaurav, any other hypothesis apart from ammonia hypothesis but regarding
ammonia hypothesis is one, Trojan horse is second, third one is this manganese deposition and manganese toxicity. Fourth one is reactive oxygen species. Fifth one is this phosphorylation, defective osmotic, this oxidative phosphorylation, specifically Krebs cycle related.
Also,
These
there
are
is
the
gabapentin or benzodiazepine hypothesis also.
yes, sir, they are also.
Also, another question I want to ask is, Gaurav, you have mentioned to explain poor prognosis. So at this stage, what are the factors that will lead to poor prognosis in this patient?
Sir, poor GCS, higher ammonia levels.
What is the quantification for ammonia for prognosis?
Sir, more than 200, 150, more than 150, it's related to the where patient should be managed, like in ICU setting, and more than 200 is related with the bad prognosis.
Dr. Gaurav, so you mentioned that ammonia crosses the blood-brain barrier, gets converted, enters the neuron astrocytes, gets converted to glutamate. Glutamate is an osmotically active agent, so it draws water. So there is an astrocyte swelling. That is one of the features, and that is how you cause cerebral edema in a nutshell. And of course, there are mechanisms by which mitochondrial injury also occurs. And then Dr. Vikas sir mentioned the GABA minergic theory, and apart from that, is there anything else which happens very importantly, which is the earliest change in terms of raised ICT, which you did not mention? Very important. There is also increased cerebral flow initially, at least initially. Okay, cerebral flow increases and there's disordered autoregulation. And why this occurs is not very clear, but there is increased blood flow, probably related to the increased circulation, the hyperdynamic circulation. Okay, so that's also very important. So why does ammonia rise actually, Dr. Gaurav, in acute liver failure?
Liver is an important site where ammonia from the body. Ammonia from the body comes from two major sources. 50% comes from the glutamine from the enterocyte. Another 50% from the nitrogen metabolism that happens in the small intestine. All of this comes from the portal vein and detoxify in the liver to urea, and that get excreted out from the renal system. Another major site for ammonia detox is the renal system that can produce and that can get rid of ammonia both. Third side is muscle. That sarcopenia patients has the relatively higher ammonia levels as compared to the normal muscle mass. So whenever there is acute liver necrosis is there, liver injury is such significant. So the metabolism of the ammonia is get very severely hampered. So the body ammonia rises and that leads to the severe consequences.
Okay. So ammonia comes from the gut and it's carried by the portal circulation to the liver. And because the liver is not functioning properly, your ammonia levels rise, and ammonia normally is converted to urea in the liver. But since the liver is not working, ammonia levels rise. Fair enough. Another question, Dr. Gaurav or Dr. Vamshi, which is very important and is of a lot of interest to our audience. They ask me many times, should we do arterial ammonia or venous ammonia? And is there any difference?
Arterial ammonia should be done. There are conflicting evidence as you go with the evidence. First we talk about theory. Theoretically, arterial ammonia reflects better ammonia status of the body because venous is site dependent thing, because ammonia can be actively taken up by the brain, muscle, extrahepatic site that are not being primarily involved in the liver injury. So venous ammonia usually lowers than the arterial ammonia and didn't reflect much. If we go with the evidence, arterial ammonia reflected very well with the prognosis with the onset of hepatic encephalopathy in the outpatient cirrhotic patient as well as in the in-hospital patient. Venous ammonia, some people has done the study. Recent literature has come out. They says there is no much difference, but older literature still says venous ammonia doesn't correlate well with the prognostic as well as the other values associated with the ammonia. So arterial ammonia is preferable. It has to be transmitted as early as possible. It should be done in 1 hour. Fist should not be closed. Tourniquet should not be tight. Preferably non-refrigerated samples. So these are the limitations. That is why we have a broad range of ammonia reference level as well. But nutshell, arterial is preferred over venous.
Very good. So arterial levels are greater than venous, and venous levels are variable. That's why venous is not used. All the parameters like cutoff of 150 for doing dialysis for ammonia levels and prognostication are all with arterial ammonia in acute liver failure. And ammonia levels correlate with cerebral edema, but not with the degree of hepatic encephalopathy, because there are many other factors which can lead to hepatic encephalopathy. So that's very important. And though your nephrology people did not agree to do the dialysis, this is a case for dialysis, because by doing dialysis, you lower the ammonia levels. Ammonia is dialysable. And this is a direct correlation with the prognosis. It's very important. This is a very important feature because you lower the cerebral edema. And cerebral edema is the leading cause of mortality. Though in recent times, the leading cause of mortality has become sepsis and multi-organ failure. So if your ammonia is going more than 150 or arterial ammonia, this is a very clear indication to do dialysis. And the modality of dialysis is CRT. Because when you do CRT, you remove the solutes in a slow manner. So there's no sudden flux and there's no sudden fluctuation in the intracranial tension. So, apart from acute liver failure, the other indication is hypotension for doing CRT, where it is very clear that there's a distinct advantage over doing intermittent hemodialysis. So acute liver failure is one of those conditions, or conditions where you don't want sudden fluxes in intracranial tension, because in CRT, the solutes are removed smoothly. This is very important here. Now, coming to the point, why is venous ammonia lower and inconsistent values as compared to arterial ammonia? Dr. Vamshi, any comments?
Sir, venous ammonia is actually ammonia which is being circulated in the body. We draw ammonia from the venous system, which has already circulated through the body, and already the hepatic, whatever the hepatocytes or the remaining hepatocytes are there, they are being converting the ammonia which is already there in the body. So when it is arterial ammonia, it is the ammonia which we get, which is not actually metabolized by liver. So usually, as such, arterial and venous ammonias usually correlate. That is what the recent evidence says, that both correlate with the amount of encephalopathy, encephalopathy, but maybe the arterial is a little more specific.
So the difference lies in the fact that there are two circulatory systems for ammonia. See, ammonia is produced mainly in the gut. From there, by portal circulation, is carried to the liver, and from liver, it goes into the IVC to the heart, and is pumped out into the arterial system. So if you take it there and then, you get a stat value. Now, if it goes into the venous circulation, from the arteries, it goes to the muscles, and in the muscles, the ammonia is removed and converted into glutamine, and then it comes back into the veins. And this extraction varies from state to state, from muscle to muscle, from side to side. So there is a variability in the venous ammonia, and it is much lesser because it is removed from the arterial system. That is the problem with venous ammonia, and that is why you get inconsistent values, and that is why it is lower. It is removed. The arterial circulation pumps out full-blooded ammonia, because that is the ammonia which is carried from the portal circulation back to the liver, back by the IVC, into the right heart, into the left heart, into the arterial system. And then from the arterial system, it is pumped out into the arterial circulation, small arteries, into the muscles, where extraction occurs. And this extraction leads to a lowering of the ammonia which is carried back by the venous system. That is the problem. And if you take it in the central vein, it will be the same as the arterial system. Take it as central vein. Understand? I think it should be clear now. Okay. Now, very importantly, we should move on. Let's move on, Dr. Gaurav.
There is another, sorry to interrupt, sir. There is another potential marker also which is coming up for measuring the levels of hepatic encephalopathy. Nowadays, gastroenterologists are refraining from actually doing ammonia levels for diagnosing hepatic encephalopathy, nor treating hepatic encephalopathy. There is another new potential marker which has come up, like tyrosine, nitrotyrosine, which is usually elevated in minimal hepatic encephalopathy also, where we can diagnose hepatic encephalopathy in early course.
So I'm not aware of this. There might be some studies going on. It has not yet entered the prognostic and diagnostic models of ALF. Definitely, in acute liver failure, ammonia has to be elevated. We do not use it in the standard definition, but you cannot have ALF without elevated ammonia. Whatever values you have cut off, ammonia has to be more than that in ALF. So this also may be a marker which is being tested and clinical trials, but I'm not aware of this, and it might be having some other values also. But as of now, it has not entered any diagnostic or prognostic models. Maybe you can tell more about it.
Yeah, it's a upcoming now marker for the hepatic encephalopathy.
Okay.
Which
So,
they say.
Any comments on this?
Huh?
You have any comments on what Dr. Vamshi is saying? Iocyanate or something he's saying?
Nitrotyrosine.
3-nitrotyrosine.
Yeah, 3-nitro.
That has been used for mostly in cirrhosis cases, but we have never used that. And what is the clinical utility, I don't know, but I know this has been now.
It might be in cirrhosis, because in cirrhosis you do not always get ammonia levels high.
Yes.
I don't think it should be for ALF. I have not read anything like this.
I also not know, sir.
Dr. Gaurav, you have any idea?
No, sir. These markers are actually for the patients for which are managed at, like, for us long CLDs, and they are trying to pick up it as early as possible. So
Okay,
I don't know. I haven't remembered.
Move on.
Okay, sir. So for the course, when we on receiving his GCS, arrival was V1, E1, VT, M1. Vitals was stable. Mechanical ventilation started with assist control mode. General physical examination, there was no pallor, icterus present, no edema, no clubbing, no rashes was there. Systemic examination, CNS wise, he was E1, VT, M1 without any sedation. Dolce maneuver present, pupil dilated but reactive to light, bilateral plantar mute, hypotonia in all the four limbs, no neck rigidity was there. Hemodynamically, he was stable. Per abdomen, soft, no tender, no guarding, no rigidity. no hepatosplenomegaly. Respiratory wise, no added sound was there. No, there was normal vesicular breath sound was there bilateral.
So, Dr. Gaurav, just go back, please. So, doll's eye present means what, Dr. Gaurav?
Usually, Dolce maneuver, there is a testing for this brainstem reflexes. So once we turn the patient's head suddenly towards one side, eye gaze to fix at that point only. It doesn't move along with the this thing head thing. So if it is there, then that means patient has an intact brainstem reflexes. If it is not there, then Dolce is absent. Then patient might have a compromised brainstem
So, absent
because
doll's eye means what?
absent dollar means it is not moving along with the head movement.
So, if you move the head to the left, the doll's eye should move to the which direction if to say it is present?
Dolce should be either remains in the midline or wherever it is, or otherwise it goes with the head movement.
Dr. Vamshi comments doll's eye movement.
Usually, also it is an ocular and oculocephalic reflex, which means the brainstem reflexes. When you turn the head to the one side, the eyes move to the other side. It's the normal oculocephalic reflex. If it's absent, that means we take it as a sign of brainstem there.
Well, yes, actually, that's more clearly put. So, actually, you see, when a patient is conscious and you turn the eyes, the head to any direction, the eyes remain central. That means the patient is conscious and the brainstem is intact. When the patient is unconscious, you want to see the integrity of the brainstem. In that scenario, you move the head to, let's say, left side. And if both the eyes move to the right side, that means the doll's eye is present and the brainstem reflexes are all intact. Your brainstem is intact. Simply, that is the simple interpretation to put it that way. So that is the interpretation. Now coming to lateral plantars, mute, uh, hypotonia or limbs. Any comments on this, Dr. Gaurav? Bilateral plantars, mute.
CNS wise, he is like even VTM1, so there might be a reduced sympathetic corticospinal outflow that might causes the acute hypotonia or bilateral plantar muting of bilateral plantars, but it has to be evaluated over the upcoming course of the disease because it's a initial finding we find it out, but as per say he doesn't have any injury to cervical cord or anything involvement at the cervical cord level acutely. So chances are that this pathological state or any this kind of direct injury to the nervous system is not involved. It's primarily secondary to the whatever CNS involvement he is having. So
Yeah,
at this point of time, we might attribute it to this, but over course of time, we will see.
yeah, it is, when you do a neurological examination, it is very important to look at asymmetry in the signs. So that
Yes.
is one of the key features in localizing focal lesions in the brain. That gives you a pointer towards a focal pathology. Any asymmetry in your... Okay, Dr. Gaurav, move on.
On focus, bilateral A profile anteriorly, right flap point shred sign with dynamic air bronchogram. With left flap shows a minimal effusion with static air bronchogram. Query or might be aspiration or evolving HAP or WEP. Echo-wise, normal biventricular systolic and diastolic function. No valvular etiology was found out. No effusion was there. DVT bilateral veins are compressible and no echogenicity was found. ONSD was done. It was raised on both sides. 0.88 on right, 0.82 on left side with elevated disc height. TCD was done and showing the pulsatility index of 2 that corresponds to the ICP of 21.62. So all of these features suggestive of focus suggestive of raised ICP that we have in the ED as well, along with the evolving lung lesion that might be a evolving in hospital acquired infection.
So, Dr. Gaurav, what is the cutoff for ONSD for raised ICT?
Sir, it might be interpreted in two way along with optical disc height elevation or not. If no disc height elevation, 0.45 or 0.5 is the cutoff for the things to consider as a raised ICP. But if we with the marginal cutoff like we are getting 1.45 or 0.43 with elevated disc height as well. So literature is there that can say that we can label this patient as a raised ICP. So 0.45 is the cutoff with or without elevated disc height.
And what is the formula for calculating ICP from TCD? Just what are the components you need?
Sir, this one thing is this pulsatility index. That signifies this thing that comprises of formula peak systolic flow minus diastolic flow by mean flow, and from this pulsatility index we have a formula to calculate TCD. This TCD originated this ICP values.
Okay, so move on then, next slide.
Chest X-ray and presentation, there is a blunting of left CP angle, otherwise remarkably normal. No evidence of any space occupying lesion or any opacities.
No,
As per the investigation,
just go back to the X-ray. So, what is the diagnosis on the X-ray? Is this X-ray?
regarding
Is this a good quality X-ray?
not exactly a good quality X-ray. We are this intervertebral space has to be visualized, just visibly visible. Like it should not be well oriented or not well be obliterated. There is a slight bit of rotation as well, so we cannot table as an ideal good quality X-ray, but
yeah, it is okay. It is not that bad, not the best, but okay, like this only. It is not that bad. But what is the you have said left CP angle is blunted. What is the diagnosis there on X-ray?
CP angle blunted, likely a pleural effusion that we see on a lung focus as well. Otherwise, there is a little bit of haziness along with that blunting of CP angle. Other chest findings are non-remarkable, sir.
No.
Lines are in situ. Center line is in place.
One possibility is there is an effusion. What is the other diagnostic possibility in this? You are saying in the left lower zone.
Evolving pneumonia, sir. Maybe
Very good.
that
Third
causes
possibility.
Third possibility.
Dr. Vamshi, any other possibility for this opacity you are seeing?
No, sir, it should be only a pleural effusion as such. Otherwise, the heart border is clear. Can attribute it to Silhouette sign is what you're thinking about.
Silhouette sign is not there. There you can see the heart border.
Mm-hmm.
So one effusion, two pneumonia, third collapse. Okay, he is drowsy and all that. It can be a small collapse at the base. Okay. So
okay.
You are seeing some static bronchogram also. Anyway.
Yes, sir.
Carry on.
And further investigation, thrombocytopenia started improving and then improved over the due course. Coagulation remained static for some time and then started improving. The create was persistently high, but at the end of second week, started improving by its own. And as per the bilirubin is concerned, bilirubin was now increasing along with the decrease in the AST-ALT levels. And ammonia was repeated on 12th of July after 4 days. It significantly come down to 65.
So here, from 9th July, which is what day, what of admission? 9th July?
Sir, 9th July is AIIMS admission day 3.
Okay.
And otherwise, illness, 9th day of illness.
So he has rapidly improved from 9th to 12th. Even your INR has come down to normal. So these are signs of healing. He has rapidly healed, right? INR is very important prognostic marker. Ammonia has come down. So he is recovering, generating on his own. The liver has started generating. Very important, Dr. Gaurav. You have showed very nicely such a detailed chart and you have made such a chart. What investigations are missing?
Phosphate are missing.
What happens to phosphate in acute liver failure?
Usually, significantly, phosphate is being used as the liver regenerate. But phosphate levels are also altered.
Liver regenerates later on. First, there is destruction.
So destruction, will be an one thing is key acute. This phosphate utilization will not be there. Another thing is kidney injury because of AKI metabolic. This excretion of phosphate will not be there. So hyperphosphatemia may be the initial finding we get. As the liver generates, liver utilize the phosphate, and hypophosphatemia actually is a marker of liver regeneration over the time if other parameters are going in the same direction. Like coagulation is improving, ammonia is coming down, phosphate is being utilized. So these all are sign of regeneration of liver.
I agree. If the liver regenerates, especially in transplant patients, phosphate goes down. That is accepted. But what happens before that to phosphate? Renal failure does not occur in all patients. So just simply, if this patient goes into acute liver injury, initially, what would you expect in phosphate? And what are the
Phosphate
factors?
will rise.
What are the factors associated with phosphate change in the serum in these patients initially?
Intracellular release of phosphate will be there to the serum level, so it
Very good.
increases initially.
Phosphate rises whenever there is cell lysis. Huh?
Yes.
One of the causes
Yes.
of raised phosphate is cell lysis. What other factors can change serum phosphate levels in patients of acute liver injury or hepatic encephalopathy? Such patients.
One thing is this release in the blood increase. Second thing is utilization is not there. So
Utilization will be there if phosphate is used in other places, not only in the liver. What else? What is the commonest of altered serum phosphate levels in the ICU? Broadly speaking.
I'm not aware of.
So, Dr. Vamshi, can you get hypophosphatemia in the
Hypophosphatemia and cardiac failure?
No, cardiac failure is a effect of hypophosphatemia.
Yeah.
So you see, these patients have hepatic encephalopathy, which leads to respiratory alkalosis. They hyperventilate, and when you get respiratory alkalosis, there is a transcellular shift of phosphate. The commonest cause of hypophosphatemia in the ICU is transcellular shifts, and respiratory alkalosis is a very important feature. And respiratory alkalosis occurs because of hepatic encephalopathy in these patients. Hepatic encephalopathy patients hyperventilate. Second, you give glucose infusions in these patients because they have hypoglycemia, which Dr. Gaurav should have mentioned or maybe forgot to or whatever. Hypoglycemia is very important in acute liver injury. Glucose has to be monitored 2 hourly because glucose is the powerhouse for glycogen and glucose stores. So when you give glucose infusions, insulin is released. And when insulin is given, insulin moves the phosphate into the cells. So you can get hypophosphatemia. And phosphate is very important here because and subsequently you get liver regeneration and phosphate is consumed. And you won't be able to wheel off the patient if you don't see the phosphate. So phosphate is important in acute liver failure. So that was what I was trying to say. Dr. Bikash, sir, anything you want to say?
No, sir, that's okay. Glucose actually you have forgot to mention, but it was monitored. There is never a hypoglycemia. Otherwise, whatever phosphate you told is absolutely correct.
So other thing is, the SGOT-PT is coming down and bilirubin has kind of increased slightly, 8.4, 8.3, 9.4, 10. So was he given any blood transfusion?
No, sir.
So Gaurav, on 9th bilirubin is 8.4, on 15th it is 10.5. And any reason you want to give for this?
As we see recovering from the liver injury, bilirubin initially increases because the capacity of liver as a marker of injury what we are getting from OTPT is okay, but the capacity of liver what is regenerated is not as good as the normal liver. So the clearing of bilirubin and all patterns are like slightly delayed. So whatever literature says, bilirubin clearance and all things lag behind as per the injury to the liver. So injury recovers first as indicated by the markers. Bilirubin remains static or slightly increased, and then over the time it comes down.
Yes, actually, the most important marker for prognosis. There are 4 markers. Prognosis is concerned. King's College criteria is there, but that is mainly for paracetamol and it's a Western criteria. And we have our Indian criteria. Are you aware of that for prognosis?
ALF-PD, sir.
Yes, very good. So what are the components?
One thing is this thing, coagulation.
Okay.
Second thing is this bilirubin, total bilirubin.
Very good.
Third thing is create.
No.
Yeah.
I forgot, sir, exactly.
It is.
So there are 4 criteria in Alfred model, which is given by India. It is for our own continent, and I think it's given from AIIMS Department of Gastroenterology. So
Yes.
4 criteria are there: hepatic encephalopathy, bilirubin, INR, and ammonia. And on the basis, these are scored, and any score more than 4 has a high mortality. So these are the prognostic markers according to our own criteria Alfred model. Alfred, ALFED. So the SGOT-PT does not figure in that. That's very important to realize. And SGOT-PT may actually improve while the patient is worsening. So SGOT-PT levels can go down, but the patient can actually worsen. And SGOT-PT levels can go down despite worsening because there's no SGOT-PT left to release. The hepatocytes are so destroyed. So these are the prognostic markers in deciding about the prognosis of ALF. Okay, so ammonia has come down, and again, ammonia, like I said, is a prognostic marker. And as far as PCT is concerned and CRP is concerned, CRP is made mainly in the liver, and CRP levels are low in acute liver failure because it cannot be synthesized, and PCT rises in acute liver failure because it is SIRS. SIRS physiology in acute liver failure is that of SIRS, so PCT levels rise. So you have to see a temporal profile as far as PCT use is concerned in deciding about infections. And you did not mention about antibiotics. I think something. Did you do any surveillance cultures or anything like that?
Yeah, I am coming on that, sir.
Okay, carry on.
So our workup-wise, tropical fever workup was negative, including the malaria, dengue, scrub, lepto. Wilson serum plasmin levels were normal. Autoimmune negative, worker negative. Found to be having a high anti-HIV IgM, which is 8.56. Surveillance cultures, blood, including blood and urine culture, was negative. PCT, as we mentioned before, is 1.64. So during the course of ICU stay, patient was on ventilator with normal pupil size, reactive bilaterally, and repeated Cushing reflexes were present during the ICU stay. Heart rate went down to 40s, BP shoot up to 200 by 100. ICP lowering measures, including 3% NaCl, propofol sedation, and thiopentone boluses was used. And ONSDs were repeatedly done that start showing a reducing trend from 0.8 to 0.5. TCD, repeated TCD was done. PI decreases from 2 to 0.9 over 3 days as correlating with the ONSD values. That was the...
Go back, Dr. Gaurav. So, Dr. Vamshi, what is the cause of Cushing reflex and what is Cushing reflex?
Cushing reflex includes the triad of it is seen usually in increased ICPs, where you have a triad of irregular respiration, bradycardia, and hypertension.
Okay, and what is it due to?
It's due to the raised ICP, sir.
No, more specific. What component is involved of the brain? What part of the brain is involved? The brainstem is involved. The ICT compresses the brainstem. That's why you get Cushing's reflex. These centers, the respiratory center, the blood pressure center are in the medulla, pontine medulla area. So the brainstem gets compressed by the ICT, so you get the Cushing's reflex. Dr. Gaurav, why do you get altered sensorium in raised ICT?
This reticular, the awakening system also goes parallelly along with this brainstems and all. So whenever there is an involvement, raised ICP is there, the RAS activation, actually this endothelial activity, this RAS activation get hampered, that leads to the altered mental status during raised ICP.
Why should RAS be altered by raised ICT?
The direct pressure effect is there that affects the signaling that causes the signaling for awakening and all.
No, it is not like that. Dr. Vamshi, why should raised ICT lead to altered sensorium?
No idea, sir.
You see, cerebral perfusion is MAP minus raised ICT. When the ICT goes up, MAP minus ICT decreases. So your cerebral perfusion decreases. So there is brainstem ischemia. There is brainstem ischemia because there is reduced CPP. Cerebral perfusion pressure decreases, so there is brainstem ischemia, which leads to altered mentation and drowsiness and uptendation. Because ultimately, brainstem is the source from which the sensory input goes upwards to the thalamus and the cortex. So you are right, our RAS gets affected, but how RAS gets affected is like this. Okay, Dr. Gaurav. Now, irregular respiration also you should have noted. I understand on the monitor, but does not always see. But it would have been nice if you had noted irregular respiration and put up some kind of a trace. Because I'm sure he might be having it. Achha, he was probably ventilated. He was ventilated. Okay. He's on the ventilator. Okay. But even on the ventilator, you can make out at times what is happening. There'll be asynchrony and all those things, depending on the degree of sedation. Now, you have given 3% NS, propofol, and thiopentone. So, Dr. Gaurav, thiopentone has some side effects. Can you name those side effects?
One thing is cardiovascular side effect. It can hampers the hemodynamic further and reduces the cerebral perfusion pressure if patient was not optimally fluid optimized. And second thing is tachycardia, that also hampers the circulation again. Third thing is the per se that molecule has to be reconstituted, so it might leads to the infection if it is reused over the particular time period.
Dr. Vikas sir, you want to tell something about thiopentone to the audience?
Thiopentone mostly it is for normally for the what is the flow chart or the flow of algorithm that we follow for managing ICP is that either you go for mannitol or hypertonic saline. If it is not, you can for a transient as a rescue maneuver you can use hyperventilation. Otherwise, hypothermia can be used. And in the last resort, people have used indomethacin and thiopentone, which is mostly available. We use thiopentone, which is much easier available. It has a very narrow therapeutic index. Mostly, it is cause some hemodynamic instability in the patient, which is already hemodynamic instable. It is may not be that much a good choice to use this one, but it is mostly used as a rescue measure or a thing that after all these things you start with hypertension, saline, mannitol, hyperventilation, hypothermia. It doesn't mark. You can use as a last resort.
Yes, absolutely. So thiopentone has no proven role. It is a rescue measure, desperate measures. And apart from hemodynamic instability, there are two other things. It causes immunosuppression and predisposes to infections. And third, it leads to significant coma and it can accumulate. And you be able to monitor the neurological status, and you need ICT monitoring. So
Yes.
this becomes another aspect of management when you start giving thiopentone. Okay, Dr. Gaurav, move on.
Gaurav, can you go back slide? So is there the management slide is missing or you are coming?
It's coming, sir. It's last this one treatment what he received. So we didn't tag, there was no bleeding manifestations, so we didn't transfuse. This tag is showing increase in R time, increase in K time, and decrease in MA.
Just lower it, Gaurav. We cannot see the trace. Just thoda niche karo. Yeah, okay. So this is the tag tracing. What is the tag showing?
Tag showing there is an increase in R time, K time, and reduced maximum amplitude. So all this signifies reduction in platelet. We already know patient is having thrombocytopenia along with increasing.
Gaurav, one by one. What does increase in R time tell you?
R time tells us the thing for extrinsic factors like clotting factors, what are there in the body that's required for initiation of clot formation.
Okay, what does increase in K time tell?
K time is the initial 10 second when the clot kinetic picks up, and this is a combination of both, including this interaction of clotting factors along with the fibrinogen.
And maximum amplitude?
Maximum amplitude 80% because of platelet, 20% because of fibrinogen. Stabilization of clot should be there.
So it is decreased here, right?
Right.
So means fibrinogen and platelets are decreased, which is the case.
Yes, sir. Likely because thrombocytopenia is there. So quantitatively we have a reduced platelet. Along with we have a prolonged K time and reduced MA, so fibrinogen might be decreased. But he doesn't have any bleeding manifestation, so we didn't go ahead with any another further investigation or transfusion.
So looking at R factor, K factor, alpha angle, and MA, maximum amplitude, what is the inference as far as the coagulation status is concerned?
Patient is hypocoagulable.
Okay, hypocoagulable. And what about the lysis? Not lysis.
LY, this CL30 and CL60 is 0%.
Meaning what?
So, meaning what? Patient is not getting this thing, clot is not getting this fibrinolized. So there is no hyperfibrinolysis.
There is no
More than 7.
So what
there is no.
what is the usual coagulation profile in a patient of acute liver failure, as far as theory is concerned, and what is the normal what do the studies tell you? What do you get in acute liver failure? Do they bleed?
Usually they don't. If because it's acute, they can bleed because hemostasis achieved take some time. But if it is because usually patient having a high endothelial release of Wolff-Wille-Brand factor, ADAM13 and all, so they maintain a hemostasis and there is a reduction in this.
Dr. Gaurav, what do studies tell? Are patients of acute liver failure hypocoagulable normally or hypercoagulable?
Studies are coming saying that treatment should be personalized. So I don't know, sir. Per se, the evidence
Dr.
indication.
Bakshi, are patients of ALF hypercoagulable or hypocoagulable on TEC, as far as the studies are concerned?
Theoretically, they should be hypocoagulable, but the many studies say that they are hypercoagulable.
Yes. So
in actual.
if you look at the reliable literature, literature is very complex sometimes. They say these patients are hypercoagulable. Okay, by and large, they are normo to hypercoagulable and they don't bleed. Don't even have to, give them supplements with the blood products if you're going to put a line, etc. That is what the literature says if you look at the reliable literature. And there is a shutdown of clot lysis, which is occurring here. There's no lysis. So these ALF patients don't really bleed, right? That is very important here. This patient is hypocoagulable. Some patients can be outliers. They can be hypocoagulable. But by and large, that is the coagulation profile of a ALF patient. Okay.
One thing I want to add, Mansur, is that rightly said, you don't change the INR in case of a ALF patient because that will if you are giving that FFP or something, that will hamper your monitoring of the coagulation because this patient does not bleed. Rather than if you are doing two procedure, focusing on a platelet count may be a better thing rather than changing the INR or correcting the INR.
Yes, definitely. And if the platelet count is extremely low, then of course you have to use platelets. But the other thing is, even with unless platelets are 20,000, then there is no option. But like borderline cases, use of TEC is definitely encouraged now. It is a point of care test which is being widely used and very helpful because it gives much more information. The management of coagulopathy in chronic and acute liver disease has changed drastically with TEC.
Yes.
Okay. Now, gastro opinion for plex. Now, any role for plex in acute liver failure, plasma exchange?
For hyperacute liver failure, that is less than 7 days of duration, less than 7 days of onset to encephalopathy, literature is coming up and it's showing promising result. High volume plex has some role, reducing the inflammation, reducing down the bilirubin and other markers. For other kind of ALF, it's still under investigation, but there is some role. If patient is not having a sepsis, replacing during supporting with the plex, replace it with the FFPs, it has some value in ALF.
So plex is advised and helpful if the patient is not improving, and it improves the prognosis and outcome in patients who are not undergoing transplant. And it is especially helpful in Wilson's disease, acute liver failure. Is grade 1 recommendation from American Plasmapheresis Association. And if you can't do plex because of some reason, then even albumin dialysis can be done.
Albumin dialysis can be done.
The difference between albumin dialysis and plex is that in plex, you remove the harmful substances and then you add good plasma. While in albumin dialysis, you only remove the bad molecules. So that is the difference. Plex is better than albumin, but these modalities can be tried. Okay, next slide.
On 12th of July, patient has the hypertension with bradycardia despite on propofol on 3% NaCl. And patient was on DVD prophylactic heparin. ONSD was raised. MRI of brain was done. ONSD from 12th July, 12th and 13th July. 11th July, it came down as we previously discussed. In 12th and 13th July, it again rises up to 0.8 from 0.5. So this was the MRI brain done. This shows the bilateral optic nerve tuberosity thickened and optic nerve head cupping. That's suggestive of increased intracranial tension. And no other significant findings was observed during the MRI. So on 13 July, patient was on mechanical ventilation, but this bradycardia episodes get stopped. Only hypertension persists. USG Kidney Doppler was done, that was normal. She was started on antihypertensives to control the blood pressure.
Dr.
The
Vikas
treatment
sir,
received,
why did you do a kidney Doppler?
Because the patient was constantly going for a hypertension, but it's very unlikely that any renal artery stenosis or something we suspect. That is a routine thing we do. Nothing specifically to that because of only hypertension.
Also, I think renal Doppler is difficult to do with portable. This must be a portable Doppler, right?
Yes, yes, it's a portable Doppler.
It's difficult. The imaging is difficult with. I don't know about AIIMS,
Exactly.
whether they have some new software, but
No, we don't have. We have the regular
it is
sonocyte machine
difficult
with
to
that.
visualize the renal arteries and do renal artery Doppler with the portable machines. Okay, carry on.
treatment received ceftriaxone and doxy continued from the ED as a part of tropical fever. Meropenem and fluconazole was added as an institutional ALF protocol. Neck infusion was continued. Rifagut syrup loose was continued as a part of ALF management, and amlodipine and alkamine was added as an antihypertensive agent.
So why was meropenem and fluconazole added, Dr. Gaurav? The patient was not doing worsening or anything, and there was no culture positivity.
Sir,
Anything?
patient presented as a altered mental status of hepatic encephalopathy. One thing. Second thing, in our institute we have a protocol. By taking this thing into the account in Indian guidelines, patient immunocompromised, there is always a dual gram negative cover along with the antifungal cover. We usually do in the every ALF patient.
No, but
Otherwise,
you
international guideline.
You started with ceftriaxone and doxy, then you have added meropenem.
So dual gram negative coverage, sir.
No, ceftriaxone will not do anything when meropenem is being given. What is the logic of giving ceftriaxone? Is there any logic of
Ceftriaxone initially was ceftriaxone, but it received for day 3 till we received the patient in our ICU.
So he was getting meropenem only then.
After that, meropenem, doxy was continued because workup was not come yet. Again, this thing, lepton scrub hasn't come. So doxy was continued, miro was added, fluconazole was added.
Okay, that's fair enough. So does fluconazole have any hepatotoxicity?
Yes, sir. Metabolized by this liver only, and it has a hepatotoxicity effect.
So any other drugs out of this has hepatotoxicity?
Doxy sometimes can cause hepatotoxicity, sir.
Yes, both doxy and fluconazole are hepatotoxic. They can be, and hepatotoxicity doesn't tell you it is coming. One patient in 1,000 patients will develop it, and it will not be written on his chart that this patient is going to get hepatotoxicity. I'm not saying what you did was incorrect. That's perfectly fine. But one should be aware of these idiosyncratic reactions. And what does ceftriaxone do to LFTs? Can it have an effect on the LFTs?
Cefoperazone has more effect on coagulation parameters because of its ring. Ceftriaxone, I am not aware of, sir.
Dr. Vamshi, any link between ceftriaxone and LFTs?
No, sir, not actually. What Gaurav said is that the cefuroxime has a effect on biliary stasis, but as such, ceftriaxone is actually in many studies, rather in CLD, ceftriaxone has come a long way to prevent any infections in a patient with CLD with a UGI bleeding.
No, that is okay. So see, ceftriaxone specifically, what it does is, yes, Dr. Ankit, that is right. It causes impaired LFTs. It causes biliary sludge formation, especially if given for more than 1 week. You are right, Dr. Ankit. It causes biliary sludge formation and can lead to increased LFTs. So one should be aware of all these things, because we use ceftriaxone so much. All side effects of ceftriaxone, doxycycline, fluconazole, meropenem should be known to us by heart, or it should be on our fingertips, because these drugs are used like water in the ICUs. Dr. Subramaniam calls them vitamin M and vitamin C and vitamin K and vitamin A. This is like that. Okay, carry on. What about arcamine? What is arcamine, Dr. Gaurav?
It's a alpha agonist that used for.
What is its pharmacological name?
This one is pharmacological name, matlab? Sorry.
Clonidine.
Arcamine.
Sorry, clonidine.
Arcamine is a brand.
So clonidine, sir, centrally acting alpha-2 agonist that has some sedative effect along with the antihypertensive effect.
It is a sedative, right?
Right.
It can have sedation, so that becomes important here. What other side effect it has, which is pertinent here? So
Post-orthostatic hypotension it can cause.
that is a different thing. Orthostatic is there is no orthostatic here. So these things, should be known very clearly. These things should be our fingertips, basics, antihypertensives, antibiotics, side effects, because these things happen all the time in the ICU. Dr. Vamshi, what is the relevant side effect of arcamine here? The patient is having Cushing's
Artemisinin
effect.
has a alpha agonist action, so it causes some amount of constipation also, which can increase hepatic
Bradycardia it can cause, but it was added after patient was stabilized another 48 hours. He doesn't have any episode of Cushing.
Okay.
And alpha agonists are notorious to cause bradycardias,
Yes.
and makes
Because
the
they,
definite.
they decrease the sympathetic outflow from the sympathetic center in the brain, the blood pressure center. So they cause bradycardia. So these things should be known. And they cause drowsiness. Don't give arcamine at night to a patient of COPD. He'll get intubated. It has happened to my patient. Okay, go ahead.
One thing, Gaurav, before this thing. So, although we started antibiotic in all the patients, is there any specific guideline to when to start empirical antibiotics in this ALF patient, or you start in all the patients?
So some guidelines, Indian guidelines, I guess, is there for ALF patient. They say as if there is an evidence of encephalopathy at presentation, or there is evidence of organ dysfunction, start empirically and do the rigorous culture and the surveillance culturing thing. After starting surveillance culture doesn't make any sense, but guideline wise, it's the organ dysfunction or hepatic encephalopathy as far as I know as the indications to starting antibiotic at presentation.
Yes,
Otherwise, it should be goal directed.
yes, it should be goal directed, and they say go for a surveillance culture, but which is practically not possible in our setup. And most of the time, we'll end up giving all the patients antibiotic. But the guideline says if you are any suspicion of clinical infection, that is obvious, or there is a progressive or advanced hepatic encephalopathy, hypertension, multi-organ failure, or if the patient is posted for a liver transplant also. These are the indications so in which you start any empirical antibiotic therapy.
Yes.
Okay. So another thing, what is the rationale of giving antifungal?
The incidence for having a fungal infection in acute liver failure with hepatic encephalopathy is somewhere around 30 to 50%. So, barring an innate immunity is going down along with the ALF, and antibiotic is also given. So, prophylactic antifungal is being added. So as you know.
The incidence one third of the patients normally have fungal infection. So it makes sense to use. Yes, you can continue.
So, like Dr. Vikas said, sir said, most of the guidelines recommend starting the antibiotics because now the commonest cause of death is sepsis and multi-organ failure. It is not stage cerebral edema. So, and these patients are very prone to infections because liver is a severe immunological function. It manufactures opsonins, complements, and when it is impaired, there is a very large tendency to develop infections. And the gut is a source of infections apart from aspiration and all those things because the gut mucosa becomes hemorrhagic and edematous. So there's infection. So most of the guidelines actually recommend that you can start the antibiotics at the outset. And AIIMS data itself has shown that 50% of the patients have an infection or develop within the first 48 hours. And like Dr. Pikasar said, if the patient is not improving or whatever your institute protocol is, antifungals may be added as deemed necessary. So that was about antibiotics and antifungals. Have a very low threshold for antibiotics. You can start at the outset. You start with the lower ones and then you can go to the higher one as required. And antifungals can be added if the patient is not improving. Okay, Dr. Gaurav, please go on.
On 15th July, patient got extubated. 16th July, that's day of 16th of illness, and day 9th after coming to AIIMS, shifted to medicinal ward, and he was fully functional and discharged from the ward on 20th July after 20 days of illness.
Okay, so please stop the share screen, Dr. Gaurav.
Yeah, Dr. Bansal, you can discuss few things regarding the. Okay, you have stopped.
Yes, Dr. Vikas.
No, you can discuss regarding the liver assist devices, a few things also.
Yeah. See, liver assist devices, basically you have the albumin dialysis. You want to say something first? You can go ahead. Maybe you have some experience.
Already you have stopped the recording or we are continuing?
No, we have finished. We have finished the webinar.
Okay.
No,
No, just
one question before that to Dr. Vamshi or Dr. Gaurav. Is there any role for any antivirals in acute liver failure?
If hepatitis E related liver failure is there, there is might a role of ribavirin, although it's implicated in a chronic disease, but acute hepatitis E ribavirin has some role.
Very good.
We can.
Any other virus?
And
commonly used? Hepatitis B, anything you can give?
Yes, sir. This entacavir and this tenofovir.
Very good.
These two.
Yes, good. And sometimes, you have herpes simplex also, which is causing, you can give acyclovir.
Acyclovir.
Though it's very rare. That's okay. So, Dr. Vamshi, any questions?
Not particular, sir. What is the role of continuing rifaximin along with the higher antibiotics? Many times I've seen the many physicians continuing rifaximin along with the higher antibiotics.
So, about continuing rifaximin, because rifaximin has a specific role in the gut flora. So that's why it is recommended. It is not recommended that
ASLD guidelines say that when you go to carbapenems to a higher antibiotic, they say there is no role for rifaximin.
See, the role for rifaximin is not proven in acute liver failure anyway. It is a plus-minus situation. And certain committees may recommend, certain recommendations may not recommend, but rifagut is a specific gut antibiotic. Gut flora is a little different. Yeah. So that is the only difference. For example, you give Metrogyl earlier, we used to give Metrogyl. After that, rifagut has come, and it has some other mechanisms of action also. So as far as at the outset, even the recommendation is not clear whether you should give rifagut or not give rifagut. So, okay. So anything else anybody wants to comment or ask? Dr. Vikas, sir?
No, Dr. Bansal, it's okay, perfectly.
Dr. Gaurav, sir, any question?
No, sir. No, sir.
Okay. So any questions from the audience? We'll wait for 2 minutes. Any comments or any questions from the audience, please? Thank you for being with us. Okay, I think there are no questions, and that's all. So I thank Dr. Gaurav, very nice presentation and lovely question answers and a lot of knowledge. All the best, Dr. Gaurav, for your exam.
Thank you, sir.
And thanks, Dr. Vamshi, for joining in. Hope to see you again sometime. Maybe you can put a case, some nice case from your ICU. If any nice case comes up, you can contact me and we can have that case here. And my many thanks to Dr. Vikas Rezer, sir, protagonist of critical care and anesthesia at AIIMS. And recently he went to Seoul, Korea, where one of his thesis papers from one of his candidates has won the best paper award, something on weaning modality and use of tissue Doppler in assessing the diaphragm. So my many congratulations to him, and hope he brings many more laurels to AIIMS and the department. So thank you, sir. Thank you very much. Thanks, Dr. Gaurav. Thanks, Dr. Vamshi.
Thank you, sir.
Thank you.